Hello, and welcome to this Clinical Care Options podcast. I'm your host, Mandy Murph. Today's episode features a conversation between Dr. Christopher Flowers from the University of Texas MD Anderson Cancer Center in Houston and Dr. John Allan from Weill Cornell Medicine in New York. The conversation is on approved and emerging bispecific antibodies for relapsed refractory follicular lymphoma, along with strategies to incorporate these agents into treatment plans. The episode is part of a larger educational program titled Research Focus in Relapsed Refractory Follicular Lymphoma, Emerging Insights on Novel Bispecific Antibodies. For more information on the speakers and a link to the larger education program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say about this important topic.
Thanks for spending some time here with me today to talk about bispecific antibodies and how they are involved in the treatments for patients with relapsed and refractory follicular lymphoma. So would love to hear your thoughts about the use of mosunetuzumab for relapsed and refractory follicular lymphoma.
Thanks, Chris. It's nice to be here with you and have this discussion. So mosunetuzumab is a bispecific antibody, a CD20, CD3 targeting bispecific antibody, of which all of our current FDA-approved agents are in the non-Hodgkin lymphoma space. Mosunetuzumab crossed that approval threshold in third line or later follicular lymphoma, and this is really where its only indication currently is. It has been looked at in other disease states, etc., but really it found a home with follicular lymphoma. The data looks great. It's there on this accelerated approval, and overall, it's a very well-tolerated and very effective agent. A few things to note about mosunetuzumab is that it is the CD20 targeting agent with the CD3 binding as well. It is given as an IV infusion. Those subcutaneous formulations are in development and will potentially have that available as well, but currently we use it as an IV infusion clinically. And the nice thing about this agent is that it's a fixed duration approach. So every 3 weeks, you get this drug after your initial induction. And if you have deep responses after cycle 8, typically in the studies, you stop treatment. And if you had a partial remission, you continued on until cycle 17, at which point you stop the treatment. A lot of patients can stop at cycle 8. Many of these patients are in complete remissions at the end of the treatment. And the other nice thing about mosunetuzumab is that it's given completely as an outpatient in terms of the ramp up of it, which is unique comparatively to some of the other bispecifics. And because of that ability to do it outpatient speaks to its toxicity profile, which is very favorable. While there is CRS and ICANS that can occur, it is rather mitigated with this agent. Patients do very well. So it's an exciting drug that we're using, and it's kind of been a go-to.
I think the other thing that's always a challenge with a single-arm clinical trial is knowing kind of how does that compare to other alternatives. And I think one of the things that they nicely did was to provide a historical comparison to copanlisib. So this really is providing a meaningful benefit, at least compared to historical controls.
There is another agent, maybe I can get your thoughts on, that is approved in follicular lymphoma, and that is epcoritamab.
As we think about epcoritamab, in the space of follicular lymphoma, the EPCORE NHL-1 trial was a large trial to be able to look at this agent in the same patient population that you talked about in relapsed and refractory follicular lymphoma. And in that trial, they had also fairly favorable overall response rates with an overall response rate of around 80%. And so it looks like an agent that has relatively similar response rates to what you see with mosunetuzumab. It also had very durable response rates for those that were responders, and within the original trial of being responses that were durable for more than a year time for that patient population. I think as we think about the role in patients with relapsed and refractory follicular lymphoma, this is yet another option, again, with single-arm data in the relapsed and refractory setting.
This is important to note about epcoritamab also, just to add a little bit, it is a subcutaneous injection, and it's been studied as a continuous treatment as well. How do we employ that? Interestingly, they have gone back and optimized the dosing for follicular lymphoma, where you can actually do this as an outpatient with 4 step-up weekly doses before you get to that full dose, et cetera, and then mitigate some of that toxicity that we see, and also is a rather easy drug to use and to administer to our patients as well.
What about odronextamab? Now, that's another drug that's been used in follicular lymphoma and then now is approved in Europe for patients with relapsed and refractory follicular lymphoma and diffuse large B-cell lymphoma.
This is one of the first bispecifics that we actually got in the clinic for non-Hodgkin lymphoma. It was one of the first studies that I took on as a site principal investigator. So I have a lot of experience with this agent and have been a part of ELM-1 and ELM-2, which is what it's got its approvals on. And also, it's a bispecific antibody. It's a CD20, CD3 targeting agent. And like all of the others, has shown efficacy in all of the disease states that we know these drugs work in. And in follicular lymphoma, that is no different. As you stated before, based on this encouraging phase 1/2 data, it does have the approvals in Europe. It initially tried to get the approvals like epcoritamab and like mosunetuzumab in the US, but there was some issues with accrual about a year and a half ago, whether or not they were going to be able to finalize the phase 3 registrational studies. That issue has been addressed now. And actually, they reapplied very recently and at this point in time has been held off by the FDA for approval. This time, it's based on production of the agent. They weren't quite ready, it seems like, to be able to get the drug out there and available to patients necessarily. With that said, it has the same kind of data we see in the same patient population, the third-line patients, high overall response rates, high CR rates. This drug is given IV. It is a little bit maybe more cumbersome to use, at least in the trials. There is some split dosing. There is 4 weekly ramp-ups. It is also weekly for 12 weeks and then every 2 weeks for 6 months and then continuous therapy monthly thereafter. And so that's how it's been designed. But nonetheless, it's another agent. And with this step-up dosing, seems to have mitigated a lot of its toxicity and is also a favorable therapeutic window from efficacy and a toxicity standpoint. And so it's another agent to use. And I guess that's going to be the big question. And if we have all three of these available, how do we sort them out? Is there one that's best in class? How do we think about these? And I think that's what we'll be talking about a little bit further on in this conversation.
One other thing to note about the ELM-2 trial, the agent appeared to be relatively well tolerated with CRS in about 50% of patients and no grade 3 or greater CRS. And at the time of the publication, at least, there was no ICANS reported for those patients. What's been your experience from being involved in the trial with the drug and how that plays out in patients that you treated?
Particularly in FL, when they redesigned the step-up dosing, we really saw it mitigate and go away. It was sometimes hard to get patients to that second split dose when we started out rather higher doses in the week 1 and week 2. But now we start in microgram doses basically, and then go to 4 milligrams and then 20 and then all the way up to the full dose. And when they instituted that kind of new step up, we really basically saw the CRS issues go away. We definitely saw the ICANS issues go away. And now we're in very low single digits, grade 3, 4 ICANS, if it's happening at all. And so it really did help improve that toxicity profile with that step-up dosing change.
And any particular challenges in performing that step-up dosing or advice to those who are just getting more familiarity with how to do that step-up dosing properly?
It's a little different with each drug and when you expect to see it. With mosunetuzumab and odronextamab, as they are IV agents, we do typically see them earlier on in the first few step-up doses, whereas epcoritamab, due to the subcutaneous formulation and the PK and of how that drug releases into the system, we actually see it at that 3rd week. You have to be familiar with these prescriber inserts. When you choose one that you're going to use, definitely look at what are the recommended times to be worried about that CRS. When should you admit patients? When is the recommended time to admit patients for that 24 to 36-hour observation? And so it's a little treatment specific. But for the most part, these IV ones, we see it like in mosunetuzumab and odronextamab, but we see it rather early on in the first 2 weeks, essentially, of it as we get higher up, and it then mitigates. Whereas with epcoritamab and the subcutaneous, we see it a little bit later happening.
I think that's really fantastic advice. Is really that step-up dosing component of it that is critical. And if you can get patients through that step-up dosing process, the rest of it tends to be administered relatively smoothly and relatively easily. When I'm talking to patients about that process, I think that's the part that I emphasize is how critical that component of it is And then the transition to continuation of therapy across the bispecific antibodies tends to be much smoother and less likely to have the toxicities that you see there.
Yeah.
When you're starting a patient on bispecific antibodies, what are some of the things that you talk them through?
Obviously, the CRS and the logistics of each of the agents is important because they are different depending on the one you're using. Telling them about the CRS risk, informing them of a potential need for hospitalization. What does that look like? How do you use steroids thereafter? And each drug is typically different. Usually, when we're talking about these outpatient ramp ups, I'm giving them some steroids to have at home, to have in the back pocket, should fevers continue on. I ask them to buy pulse oxes. I ask them to sometimes go and get blood pressure cuffs because these are sometimes things that we will never know if they just call with a fever, whether it's grade 1 CRS and you can take a Tylenol and maybe it goes away within 12 hours, or if it's precipitating into something more serious, grade 2 or higher CRS, where they're going to have to come on in. And that's where knowing the oxygen saturations and what their blood pressure and how they're feeling become important when they call you. Also, the timing of the CRS is important to talk to the patients about because it's not like rituximab where you get infusion reactions as it's infusing. You actually see these CRS events when the patient is gone and at home 12 hours later. So you discuss the timing a little bit about that. And then long term, you talk about the potential immunosuppression effects of these agents. We do see them be very B-cell depleting. We see some hypogammaglobulinemia. You do have to be cognizant of infections. And those are the big things that I try to get across. And then the timing of the scans, which are usually anywhere from 4 to 6 to 12 weeks later after you start to get that repeat PET scan to understand what that response looks like. And that's typically how the studies have been looking in the first month and a half to 2 to 3 months.
That's really great advice. That's relatively similar to the kinds of advice that we would give to our patients as well. And I think this is going to be an exciting opportunity in maybe the near, but definitely in the distant future for the kinds of non-invasive monitoring that may be available to patients as we monitor them in the outpatient for all those other things that we're looking for a patient with CRS, to be able to monitor heart rate and to be able to measure blood pressure and other things as an outpatient.
Absolutely. So there are some newer drugs that are coming around, and one of those is a newer bispecific antibody that's in development that is on the horizon. And maybe you can just give us some ideas. Surovatamig. It's a new bispecific antibody. Can you tell us a little bit about that one?
All of the bispecific antibodies that we've talked about up to this point have been CD20, CD3 bispecific antibodies, meaning that they have one arm of the antibody that binds to CD20 on the cell surface of the B cells, and then has another arm of the antibody that binds to CD3 on T cells, bringing T cells and engaging them and bringing them into contact with the B cells to be able to attack them. The surovatamig is a CD19, CD3 directed bispecific antibody that binds to the CD19 marker on the particular B cell. It's a fully humanized antibody with a high affinity to the CD19 domain, but it's expected to act in a relatively similar way. I think the thing that is interesting in this space that will be interesting over time for the management of patients with both diffuse large B-cell lymphoma and follicular lymphoma is that most recently we've commonly thought about attacking CD19 either directly with CD19 antibodies or with CD19 antibody drug conjugates or with CD19 directed CAR T cells, and using bispecific antibodies in terms of the approved agents by attacking CD20 and CD3. So this now brings that opportunity to use CD19 targeted therapy directed in T-cell engaging space. This has been tested in a phase 1 clinical trial that is now moving on to phase 2 in a single-arm modular design, both in relapsed and refractory diffuse large B-cell lymphoma and in follicular lymphoma.
As you are probably familiar with your own patients, we use a lot of rituximab in almost every line in our non-Hodgkin lymphoma patients. And many times when they're in third and fourth lines after all of this CD20 targeting exposures, many times they are CD20 negative. And a lot of the data in my own personal experience is that CD20 negative disease does not really respond very well to CD20 bispecific antibodies. So potentially targeting CD19 where we don't have tons of CD19 directed therapies. It will be nice to still offer the potential benefits of the immunotherapeutic approaches with bispecifics by CD19 in the event that maybe CD20 is low expression or completely negative in your late relapse patient.
One of the things that is planned as a trial to move forward is combining surovatamig with rituximab versus chemotherapy with rituximab in previously untreated patients with follicular lymphoma. Can you just describe in general your thoughts about that philosophy as an approach, combining a bispecific antibodies targeting CD19 and rituximab versus chemotherapy for patients with follicular lymphoma?
I think the dream for most of our non-Hodgkin lymphomas, if not for all of our lower grade indolent non-Hodgkin lymphomas like marginal zones and follicular lymphoma and CLL and even mantle cell lymphoma, is to go chemo free and potentially completely throughout their entire lifetime and treatment course. And so I do think exploring these novel approaches and novel targets against our standard chemoimmunotherapy backbone is very important, because I think that is the one way we can absolutely move the field forward and spare toxicity, spare that bone marrow toxicity, spare that immune system toxicity. As long-term data continues to mature, we are seeing plateaus in some of these curves in these patients who have been having excellent responses with these bispecific immunotherapy approaches in these even late relapsed settings. And so the potential for cure, I think, is there. And as we start to use these drugs up front and get away from chemotherapy, I think it's going to be vitally important. And I do think there is a very good chance of success there, and will be absolutely paradigm changing on how we might be treating patients in 5 or 6 or 7 years, possibly.
Yeah, for follicular lymphoma in particular, I think one of the areas that we will need to continue to address for frontline clinical trials is the ways that we measure the benefit of new drugs in that space. For exactly the reasons that you raised, is that we are now having trials that are quite successful in this space and standard of care approaches that are quite successful. That's been a focus area of my career, both in terms of developing progression-free survival as an endpoint for diffuse large B-cell lymphoma and complete response rate at 30 months for patients with follicular lymphoma in the first line. But as we start to evaluate these newer therapies in randomized trials, we will need to have endpoints for the trials that help us to evaluate them a little bit sooner, just because patients with follicular lymphoma are doing so well with our frontline trials now.
I absolutely agree. One other thing I just wanted to say is that I do think while these drugs are great as monotherapies in late relapse settings, I do think the future of them will be trying to get them earlier and earlier in treatment naive settings, and even in combinations with some of the drugs that we have. And so there's a few studies out there, phase 3 studies, that are asking some important questions. One is a SWOG study looking at mosunetuzumab versus rituximab in just low tumor burden follicular lymphoma. And then we have other phase 3 studies in the frontline setting as well, the EPCORE FL-1 that is looking at epcoritamab with R squared versus CIT or R squared as well.
Another one of the phase 3 trials that's going on is with a drug that you've been involved with, odronextamab, and that's the Olympia 5 trial looking at odronextamab plus lenalidomide versus rituximab plus lenalidomide, or the R squared regimen. Any thoughts about that particular trial and the space that it might hold for patients with relapsed follicular lymphoma and marginal zone lymphoma?
Lenalidomide, as we know, is very active in FL. While there is some use in the frontline setting, it's typically used in that second line setting. And now with some tafasitamab data looking like it's tafasitamab R squared is really standard in follicular lymphoma now going forward based on some recent data release. So it's a great backbone to put together with these drugs. It's an immunomodulatory agent. And so I think it's an important study. I think it's where all of these drugs are maybe moving to partner with an IMiD like lenalidomide. And I think this is another study that will be needed to solidify odronextamab place in this space, and also understanding what it looks like in some of these other indolent histologies like marginal zone lymphoma, where they're focusing on that group as well.
Yeah, you raised one of the key questions that is always a challenge for us, both as clinicians and as clinical investigators, and that's how will we interpret the results of this particular trial. So I think R squared still is a reasonable standard to use as a comparator in a randomized control trial. Was established by the Augment trial as the superior arm in that trial. And so comparing odronextamab plus lenalidomide to rituximab plus lenalidomide at the time that this trial started made a lot of sense. Now we will have the R squared plus tafasitamab data as potentially a new standard of care in this era, and that when we see the readout of this results, then we'll have to make some decisions clinically about how to perform if the experimental arm performs better than a control arm.
Exactly. One of these things I've just always been amazed by is how fast things move, and a study design that you think will be tried and true and still hold space for 5 years, all of a sudden gets usurped by an evolving standard of care, which then makes studies difficult to really know how it might compare to that new standard that, as tafasitamab R squared has beaten R squared in terms of that phase 3 data.
Challenging for us as clinicians and clinical investigators, but great for patients to have so many options.
Absolutely.
Okay. So John, maybe do you want to talk a little bit about the latest in this press release that came out with the FL-1 clinical trial?
Yeah, so as we've been talking about previously, how R squared is the backbone to test against as well as to combine with, the EPCORE FL-1 has released a press release of epcoritamab and R squared having improved outcomes against R squared, and that's EPCORE FL-1. This is in the relapse refractory setting. And so, we've just seen a press release. We have been told it's met its primary endpoints, et cetera. And so we look forward to the big data releases and understanding and knowing how to incorporate this. But again, it just reiterates that these drugs are moving forward. They're moving forward in combinations, and it looks like we're going to be able to potentially improve upon the outcomes of our previous standards with these agents and incorporating them into our new treatment paradigms.
Yeah. As you alluded to, it's a really exciting time for patients with follicular lymphoma in terms of the variety of treatment options that we have now available at our hands, both in terms of giving combination therapies in clinical trials, but also in terms of sequencing agents for patients. And so I think the future is quite bright for the ways that the bispecific antibodies will be used in the years ahead.
Thank you, Doctors Christopher Flowers and John Allan, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Research Focus in Relapsed Refractory Follicular Lymphoma, Emerging Insights on Novel Bispecific Antibodies, please click on the link in the show notes. And be sure to check back regularly for more episodes on important podcast topics.